Morning, everyone. I want to thank the organizers of the conference for this opportunity to speak and the opportunity to acknowledge Terry. Terry is literally the reason I set up my roots and call Ottawa home. He's been a role model for his level-headed, even temperament and leadership by example. So I'm really proud to be here for this. Some acknowledgements for the people that I work with. Great teams, as Dr. Weevils mentioned before. We have a great camaraderie between the nuclear cardiologists and our nuclear medicine folks. So thank you again for that, and for the contributions to these slides and this talk as well. So I have no relevant commercial interests to this talk. So my objectives today are to reach back in time a little bit. I'm going to bring up some tidbits from the past that influence how we read and what's involved with the imaging of sarcoidosis. So what began as a curious dermatologic oddity back in the late 1800s, these skin lesions were described at first by Hutchinson. This was kind of the first manifestations that people described for sarcoid, and later on, I'm probably going to butcher his name, Boak, he described these, he published a case series, which is where this term we use, this multisystemic disease of granulomatous etiology, it kind of came from that. So it kind of went from this weird dermatologic oddity to this multisystemic disease. And he coined that term sarcoid with a K because they kind of looked like sarcomas at that time. So, like I said, that's where this phrase multisystemic granulomatous disease of unknown etiology came from. It's kind of weird. We're trying to characterize a disease for which we still don't really know what the actual cause is. But its pathologic hallmark is that we have these non-casein granulomas, most often associated in the chest and the lungs and the lymph nodes. But the cardiac system is actually the third most frequently involved organ system. And because of that, it has great import. It's relatively uncommon, but potentially fatal. I know about a quarter of patients, you see them on autopsy reports. And its clinical presentations are variable and often tough to elucidate, but they do have some commonalities. They can have some failure, they have conduction abnormalities, and the antemortem diagnosis is challenging because of this variable presentation. So reaching back a little bit, in terms of trying to diagnose this disease, there's kind of two approaches. One is you either biopsy it, you can see granulomas, you got your diagnosis. But then the more challenging group is to try and diagnose it clinically. And if you look back at the Japanese guidelines from back then, I highlighted two parts here where you can either on imaging see a defect in the myocardium on perfusion imaging, or you see actual accumulation of a inflammatory tracer, which at the time was gallium-67. So keep that in mind. Other ways to diagnose the disease, obviously you can biopsy it. It's pretty specific if you actually get granulomas in biopsy, but it's insensitive because the involvement of the heart is fairly heterogeneous. You tend to biopsy the apical septum when you float the wire down. So imaging in cardiac sarcoidosis was initially quite challenging in this context. Also because in a lot of the early literature, a lot of it came from Japan, so it's a very slightly different patient populations and different impact on the diagnostic generalizability to other centers. So we bring out to FDG PET. As most of you know, this is a tracer that localizes to inflammation and tumors. And when we use it to assess for cardiac sarcoidosis, you actually highlight the inflammatory uptake that's associated with active disease. So this is where the lexicon for how we read comes from. Back in about, sorry, the references are cut off here, but 2005 or so, a Japanese group, he coined these patterns where you have either focal uptake, multifocal uptake on diffuse uptake, being positive for sarcoid. This is where it comes from, right? So, but you also note on the left, there's also a none pattern, so a negative pattern where there's no uptake. It's not physiologic because there's no uptake, there's just zero uptake. But you also have this diffuse pattern, which people tend to forget. It's actually non-specific. It doesn't mean there's no sarcoid, it doesn't mean it's normal, but it's just a non-specific pattern. So going back to them, this is where that comes from. And around that time, a lot of the literature at the time was fairly limited number of studies. They all came from single centers and from one particular geographic region, so they're difficult to generalize. But they did find that with FDG PET, people are starting to recognize that it detects myocardial abnormalities more frequently than just looking for a perfusion defect, much better sensitivity than gallium. And its usefulness is that you're actually visualizing the active inflammatory process at the time. The contribution to the diagnosis from looking at perfusion defects comes from this spectrum of the disease. So we recognize that you can have active inflammation early on in the course of disease. You may not actually have progressed to scarring, but you have this continuum that you can see. So in terms of perfusion defects, it's sort of limited sensitivity for looking for sarcoid, but it's fairly specific. If you see a defect, you had a chunk of myocardium that was affected by the granulomas. But if you put the two together, you find that there's actually a negative correlation between the actual intensity of the uptake of lesions in cardiac sarcoidosis compared to the segmental disease score. So what that means is that early on, the uptake in the lesions in early disease is quite hot. It's very active. But you might not have many defects yet because it hasn't actually scarred over the myocardium. But as time goes on, you get this progression to more chronic disease where you have some scars forming, but the actual intensity of the uptake starts to go down with time. So, and that's what this shows very nicely. So this speaks to the spectrum of disease that you can see. It's not just an all-around. It's not just you either have active disease or you have non-active disease. There's actually a spectrum where, as I mentioned, early on you get active uptake and you get some, but you may not actually have some scars, all the way to the other end where you might actually have no active inflammation, but you have lots of scars as a result. So one key thing to remember, it is actually a spectrum of findings that you see in these patients. The diagnostic performance of FDG PET, we know this now, it's pretty good. This is actually from our center from back in late 2000s, where we had this meta-analysis of the Ontario data, and it showed fairly good performance with a good area under the curve, 93%. And this has been borne out in much later meta-analyses. So this is in 2020. And they show fairly similar good diagnostic performance of FDG PET for sarcoid. So it works. And such that, if you recall back to the original Japanese statement, this consensus statement much later on now, 2014, has sort of updated a bit. So instead of perfusion defects, we have gallium-enhanced NMR, which shows scars. And then instead of gallium, we have now cardiac FDG PET uptake. So this kind of illustrates how things change with time. You know, what's old is more new again now. And this is the current consensus statement for diagnosis of disease, and it now integrates FDG PET into the algorithm. But as you know, if you read cardiac, if you read oncology PET, the normal uptake of FDG in your myocardium is quite variable. In an intra-patient fashion, this is the same patient, he has lymphoma. You can see over multiple time points, the uptake in the heart changes. And these are all studies where they've been fasting overnight, etc. So the uptake within the heart is actually quite variable. So if you wanted to use an imaging study where you're trying to call any uptake as a positive, true positive finding, you need to try as best as possible to minimize this physiologic uptake of glucose. So there's a few ways to do that. And also, before I get to those, this slide is slightly out of order, sorry. But you also need to recognize that any uptake you see in the myocardium might not necessarily actually be disease either. Right, so not every hotspot is disease. So we've recognized some normal variants of the FDG uptake in the heart. So there's been mild diffuse low-grade activity in the lateral wall that's been described as a normal variant. You can see it on the left. People have described basal rings of uptake, like all the septal segments. If you see a ring around the base of the heart, that's a normal variant. Even a partial ring can be a normal variant. So there are normal variants of uptake. Again, not every hotspot of FDG in the heart will equal inflammatory disease. But it's not super straightforward sometimes. I'm going to show obviously cases that are clear cut, but sometimes we have these cases which are just there's some mild patchy uptake here and there, and it's really sometimes very hard to come down hard. And the image on the right is an example of that. I'm sorry, it's not actually spinning, but it shows some mild patchy activity in the myocardium, but it's not in the typical pattern of multiple foci like you saw on the previous slide. So it's not as clear cut sometimes. Oh, it does spin. Okay, so the image here is just someone that was being evaluated for cardiac sarcoidosis, and obviously they have intrathoracic disease, but the cardiac image involvement was a little questionable just because of its distribution. So going back to patient prep, there's two ways to make sure that you make your heart not use glucose. All right, so as you know, if you're fasting, you promote free fatty acid uptake. So two ways to do that. One is you actually make the patient have increased levels of free fatty acid. You can put them on a high-fat, low-carbohydrate diet. That's one way. And the other method is actually use heparin. The way heparin stimulates free fatty acid is it actually, by way of a lipoprotein lipase, it actually hydrolyzes the triglycerides and increases your free fatty acid levels in your bloodstream. So those are two approaches to sort of maximize the utilization of your myocardium of free fatty acids and thereby minimize any sort of normal FDG uptake because of glucose. So with regards to the diet, there is this, there's sort of a range of recommendations, but they all pretty much mean that you want to use as low carbs as possible and high fat as possible. Some places will have, if you actually look at the foods that they can eat, it's akin to like a keto diet almost. Some people will put them on for like a good 24 hours before. Some other centers will just have them on the night before. Various interpretations of this keto diet are a little bit more appetizing than others. So because this is described in sarcoidosis and a lot of the Japanese literature, this looks a lot more appetizing than some of the diets that people have recommended, which is just basically more meat. This looks a little bit more appetizing. But the key is that you want low carbohydrates, less than 5 grams. So why heparin? Well, so this came about, again, reaching back a little bit. 2005, the Japanese group found that if you injected 50 units per kilo, 50 minutes before FDG, that really helped suppress the uptake. That is not an insignificant dose, though. We're talking about almost potentially therapeutic levels that might affect their coagulation. So when we were investigating this, we actually looked back a little bit in time, and with the benefit of some pharmacologists and people who have a long hindsight, they found that there's some. If you look at the images on the left, if you give small doses of infection heparin at 5 and then 10 mics per kilogram at some times before the FDG, that is enough to make sure that your free fatty acid levels are going to be as high as they're going to be, but it's not high enough that it's actually going to affect your anticoagulation. So it's kind of a subtherapeutic level, and with those doses there on the right, you can see that your maximum suppression of FDG uptake occurs around those doses as well. So that's why we've adopted that as the local protocol. Again, not broadly validated across the world, but we do it if we can, because anything we can do to try and minimize the uptake of the heart normally will help. So our local protocol is to use this low dose heparin. So we put them on the diet overnight, long fast overnight. Some places have described 18-hour fast. I can't imagine how not eating for 18 hours, but those are other approaches people have had. And then the infection heparin if you can. Our protocol is to do the whole body image first. So that's about 60 minutes after the injection. And then you get a dedicated cardiac acquisition about half an hour after that. And then we always couple it with a perfusion scan. So it's either rubidium or ammonia PET. So I'll show a couple of representative cases. And again, I'm reaching back in time because these are kind of the representative cases that we've used to build our experience at our center. So this is a 54-year-old guy. He has a NSVT presented, family history as such. And they want to make sure there's nothing going on in his heart. You can see that it's absolutely completely normal scan. There's no uptake in the heart, and this is a normal scan. Compared to case 2, this is a younger fellow with myocarditis actually, but there was no delayed myocardial enhancement on his MR, and when they did the FDG PET, you see this diffuse intense uptake all throughout the left ventricle. Could this be diffuse sarcoid? I guess, but this is one of the examples of non-specific uptake. This is not, you can't come out and say this is positive, nor can you really come out and say it's negative. He had myocarditis. So this is an example where this kind of diffuse uptake is not a specific finding. This is a person who, she had breast cancer. She does have adenopathy in the chest. However, it was more favored to be sarcoidosis rather than metastatic disease from breast cancer, and the biopsy was negative for malignancy. So they were being investigated for sarcoidosis, and actually, as you can see here, that all the lymph nodes light up. You have some lymph nodes in the abdomen as well. But there's absolutely zero uptake in the heart. You can see it's just a blood pool activity for the FDG and no perfusion defects. So this is negative for cardiac sarcoidosis, but she does have very florid intrathoracic nodal uptake from the intrathoracic sarcoidosis. So negative for cardiac. Compared to this case where this is where there's biopsy confirmed sarcoid with granulomas, and you can see on the non-rotating FDG whole body image that there are several there's several foci uptake in the heart. There's also active disease, active uptake within lesions in the lung, lots of lymph nodes, and throughout the skeleton. So one thing we've started noticing when we do whole body imaging, which is essential, is you can actually quote unquote stage where all the other lesions are, and we've discovered that the incidence of extrathoracic sarcoidosis and things that light up is a lot more than what people might have thought of in the past. So here in this patient, you can see that the active lesions on the FDG, which is on the grayscale, they correspond actually to a perfusion defect as well. So this is a little bit later on in the stage of disease that corresponds to the delayed enhancement you see on the MR perfectly as well. So this is a little bit more progressed in the stage of disease. MR is a complementary technique. It will detect the fibrosis and the fibrotic lesions in the late gadolinium enhancement, whereas FDG detects the active inflammatory lesions. So they kind of go hand in hand to help to demonstrate where in the spectrum of disease a patient is. So going back to this patient who had the active inflammation, they were put on steroids, and you can see that not only did the cardiac active inflammatory disease resolve, but all the other lesions in the rest of the body, like the bone lesions, the lung lesions, they also resolved as well. So we've recognized now it's just a natural evolution where FDG is an imaging agent for active inflammation. You can go from using it for diagnosis to actually use it to follow patients now. And it's fairly well described for that now. This is another patient who has pulmonary sarcoidosis on CT. You can see on the rotating PET image there's also multifocal regions on diffuse uptake in the heart. So they had cardiac and pulmonary sarcoidosis. The image on the right is their gallium scan. And you can see that there is zero uptake in the heart on the gallium scan. So this just shows that although gallium uptake of sarcoidosis is fairly specific, it's not as sensitive. And that's one of the reasons why FDG is superior in that regard. However, we all remember our poster cases of what gallium-67 looks like for sarcoidosis. We have these two terms, the panda sign and the lambda sign. It took me years to figure out why they called it a panda sign, because I'm looking at the image on the left, it doesn't look like a panda to me. But the more I try to download pictures of pandas, I am starting to see the resemblance now. And then the lambda sign, which is the intense uptake within the paratracheal lymph nodes, the higher lymph nodes, you form this kind of characteristic lambda sign. These two signs, although we may start to not have as much exposure to them going forward, because pretty soon we may not actually have gallium-67 available anymore, we still have to remember that. So like this patient here actually presented to the oncology unit with this lung lesion, which they're going to work up for lung cancer. And so we did a PET to stage them, and their PET actually showed kind of minimal uptake in lung cancer, but then all this other FDG have a disease everywhere. So there's lymph nodes in the chest, there's lymph nodes in the abdomen, there's some lung lesions. So obviously probably not related to this tiny lung lesion, but then, you know, there's obviously disease elsewhere. However, if you kind of look at the MIP, it kind of looks like a lambda sign. So we need to not forget the appearance of what sarcoid looks like with gallium, because this case here, we suggested this is probably not lung cancer. This is probably something else. It looks like sarcoid. In fact, you can see some focal lesions in the heart. In this case, actually did have biopsy-proven sarcoid in both the inguinal node that we directed them to and some of the hilar lesions. So they actually went on into our sarcoidosis program straight from the oncology program and was followed for sarcoid instead. So we don't want to forget what things would look like on the gallium, even though it's old. The new way of looking at it would be the FDG PET. This is another case where we had, actually it's the previous case, where we had the lung and the cardiac involvement, and they were put on prednisone, and you can see that the lung disease kind of resolved. Still some activity in the heart. Again, not totally typical in its distribution. It's not the multifocal disease that we described, but this is where having comparing it to all your previous studies is super important. I mean, you can't just look at one study in time. Sometimes if you have some sort of atypical patchy appearance, if it kind of matches the appearance on the original study, which was called fluorally positive, that helps. You can't just read one study in time. You have to compare it to all your previous as well. So this is kind of like a partial response to prednisone. I apologize, these don't beat anymore, but it did show that the ejection fraction improved. So this concept of using FDG PET to monitor treatment and look for relapse is now quite well recognized. So if you have a positive PET, you put them on treatment, and then you repeat it to see if there's been a response, and to sort of categorize patients into responders or non-responders, with the intent that if they did respond, maybe they could consider tapering them off their highly suppressive agents of steroids and such, because these biologics and methotrexate, they aren't kind to the body. Here's another example. On the left, the patient had quite a lot of cardiac and intrathoracic disease. They were put on steroids, and pretty much most of it went away in the middle scan, so it responded. But then when you try to take them off the methotrexate, the disease came back. So this is a case of someone who yeah, they responded, but they also recurred. So there's this lovely term one of my colleagues used, the term recrudescence of disease. So I use that on my reports now. It just sounds cool. So the disease came back. So this is from our group here. They published that you can actually divide these patients into groups of those who actually responded at first, but then they relapsed. All right, so you can separate these into groups of acute sarcoidosis patients versus the chronic cardiac sarcoidosis, where they keep coming back. The disease keeps relapsing. And you can see that here in the SUV values. So on the topic of SUVs, people have wondered whether or not SUVs you can use it as a hard cutoff or diagnosis. At first, it was very difficult. I mean, if you look at some of these papers from back then, there's a whole range of values for the heart. They range anywhere from like 8s to 4s to 11s. I mean, they're intense, but at first there was no real cutoff, you could say, where if it's over 10, this is automatically disease. But you can use it to try and monitor in the follow-up. So in this paper here, they show that if your SUV goes down, you actually have a correlation with your improvement of your LV ejection fraction. So it is useful in the sort of this serial follow-up sense. Last case here is a 49-year-old fellow who has known cardiac sarcoid, only cardiac sarcoid. You can see no disease elsewhere, and he declined to have an ICD put in, and this patient had that focal and diffuse pattern. So, and he had some scars already on MR. So he comes back for a repeat study later on, and even though it's on steroids, he has ongoing active inflammatory disease. Scars are getting bigger, more inflammatory disease, more scarring. So he's progressing now, and now he agrees to an ICD. So it's good to help to guide therapy. So if those of you remember back to this book we use in nuclear medicine called the gamuts, you look at the differential diagnosis of an octreotide scan. I mean, octreotide scans, you typically use these to diagnose neuroendocrine tumors and such, but there's always that 10 or so list of other things that will take up octreotide. And in that list, there is sarcoidosis. So it's always on the differential. So people have sort of taken the newer version of octreotide scans and using gallium-68 dotatate to see if this has any potential utility in assessing sarcoidosis. Literature is not quite mature on that right now, but people are investigating it, especially since gallium dotatate is so widely available now and used for other reasons like neuroendocrine tumor. So it's a nice study where you sort of this relative concordance of the FDG, the MR, and the gallium. There are some differences, and the actual distribution of the lesions is a little bit closer with FDG to the MR. And then looking forward, a very hot topic, hot tracer nowadays is FAPI, gallium-68 labeled fibroblast activation protein inhibitor. And there is a center that has used that, started to use that to see whether it lights up cardiac sarcoids. So here you can see on the left the intense activity within intrathoracic nodal disease and cardiac sarcoid, and pretty much the same distribution of active lesions on the FAPI scan. So very exciting. FAPI they're using it for lots of oncologic indications, but obviously it also lights up some sarcoid as well. So a summary, FDG PET, we know now that it's accurate by diagnosis. You absolutely have to pay attention to patient prep to make sure you minimize the physiologic uptake before you call anything positive. And in the sense of other modalities, it's complementary to MR. And there are lots of new imaging targets that are coming up, new and old, which may sort of contribute to a more comprehensive multimodality approach to imaging of this disease. So with that, I want to thank you for your attention and also welcome everyone to our city of Ottawa. Hopefully you can get to see some of it despite the rain that's coming.